Virginia, what are your like first and second line standards of care right now for metastatic HER2 positive breast cancer?
So assuming somebody has not just finished DCHP.
Yeah, assume it's 12 months after. These are like or de novo,
Sure.
yeah, right.
So the de novos, it would be the Cleopatra regimen, so a taxane plus HP. Then second line would be TDM1. We have the TDM1 versus DS8201 trial, so I try to put all of those patients on that trial. So those are my first two lines of therapy in the metastatic setting.
So basically, it's THP followed by TDM1. Correct. Is that pretty much the consensus? Anybody have any other nuances that you would do here? Probably not.
Nope.
All right.
I would agree.
Good. So then we get all right. So we're all fine with that. Now remember, all of us who have traveled around the world, realize that TDM1 is not available everywhere. That's the one thing we don't realize in the U.S. You go to like the Philippines or somewhere else, they can't get it. And it's really interesting how people are doing their treatment. They're just, at least in my experience, I'm curious what you guys have to hear. You've heard use a lot of capecitabine, trastuzumab. There's a lot of that use. There's a lot of like relbeing, trastuzumab, the stuff we used to use like 10 years ago. We didn't have any of this stuff. I mean, is that your experience outside ex-US and ex-Europe or the wealthier Asian countries? Trastuzumab.
Absolutely. And this is where a clinical pearl, like you mentioned, the TOPO2 gene amplification story, this could be useful in those jurisdictions. For instance, if you can't get another HER2 targeted agent and those patients are still anthracycline naive, which many are in this era, then 35% of those patients will be TOPO2 amplified, and those patients do benefit from single agent anthracycline. So
single, not with tras, just by itself.
Just by itself. I mean, I remember back when in the era where ex-US it was hard to get trastuzumab, and it still is in some areas of the world, in sub-Saharan Africa, et cetera. Yeah. So at any rate, in those jurisdictions, or even now, patients who have already had, let's say, antibody-based and chemo-based treatments in the neoadjuvant or adjuvant setting or first-line metastatic even, if they're still anthracycline naive, that's still a therapeutic opportunity. Of course, they won't be able to pay for the FISH test. That's the problem in those jurisdictions.
Right, you need a cheap, well, there are cheap FISH tests if they really want to do them, but that's a whole other issue. All right, so anyway, so that's it. So now we get to like the big mystery of our business. Well, not a mystery anymore, but third line therapy, so you've got people through, and Carrie, I'll boot this to you first. I mean, what are we really trying to do in third line and beyond? Is it the brain? Is it systemic? What is it? We all know how many percentage of people relapse in the brain by third line. Isn't it something like 50% or something? Some high number.
Sure. So upwards of 50%. At that point in time, we will be managing both intracranial and extracranial disease. So in our patients who have extracranial disease, we also are hopeful to prevent intracranial recurrence. So I think in that setting, really the brain metastasis consequences is either on our mind because we're actively treating disease in the brain, or we're trying to prevent that patient from developing CNS recurrence.
Right, and so we're really getting this dilemma. It's like a brain, non-brain relapse, right? The brain dominant versus the non-brain dominant. Anybody have any comments on that? I mean, because there's some interesting stuff that's come out of this ASCO that's going to really speak to this. We'll talk about it in a few minutes. But, any comments you guys want to make that do you agree that it's the brain? Is that kind of how you're thinking of this third line and beyond? As a brain, non-brain kind of dominant thing? Mark, what do you think?
I mean, the most impressive brain metastasis data at this ASCO was the data presented by Lynn, the CNS subset analysis of the HER2CLIMB study. 68% reduction in risk of CNS PFS in the Tucatinib arm with statistical confidence. Median CNS PFS was 9.9 months in Tucatinib versus 4 months in the control. Risk of death overall was reduced by 42% in the Tucatinib arm with statistical confidence. Median OS was 18 months versus 12. Overall response rate intracranially was higher in the Tucatinib arm. Median duration of response intracranially was higher. So boy, I mean, every attribute you look at with any metric of CNS disease activity, Tucatinib clearly is superior. So
that's a shout out to Rashmi. It's a shout out.
Yeah.
Good job. She's the PI study. Good job. Excellent job. But anyway, no, seriously, I mean, that's really dramatic. And the cool thing about that trial, and Rashmi, you can comment on this too, is that in the patients with stable brain mets, right? And you can define it for our audience. What you define as stable? They did not have all those benefits. That's the weird thing. is that it was really only in the progressive patients. So in other words, what I think people were thinking is that this was like the people with stable brain mets were dominated by their systemic disease. The people with the progressive brain mets were dominated by their CNS disease. I mean, Rashmi, can you comment on that? Because we waited for this data. This was our question at San Antonio, and you gave it to us finally.
Yes.
You want to comment on that?
Yeah. So
Harry,
in the study.
Let Rashmi talk first. Yeah, go ahead.
Yeah, go ahead.
Go ahead.
So the study was, it enrolled patients with stable as well as progressive or new brain metastases, and about 50% of the study actually had some history of brain metastases. And I think of that, about 40% actually had what we would consider to be active brain metastases. So that's either new disease that was found on the baseline MRI or progressing disease in a patient who had prior history and treatment of their brain metastases. So, I think in looking at the results, it is very important, as you brought up, to note that these were not patients who just had a history of brain metastases with stable disease. I mean, of that patient population, 40% had what we would consider to be very high-risk brain disease, new disease, or progressing disease. And so, and I think that also brings up the question, with the labeling, the FDA approval and the labeling of Tucatinib, technically, we would be allowed to use this after just one line of in a metastatic setting. And so certainly, as Virginia pointed out, we also have the TDM1 versus DS trial. So a lot of our patients do go on that study. But, in a patient who has CNS relapse, it may be important to give some thought for actually use of this Tucatinib regimen, especially after the results we saw at ASCO, using it actually in the second line setting after even the Cleopatra regimen before TDM1. Although in the HER2CLIMB study, 100% of the patients had received prior TDM1.